Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article Human Papillomavirus and Overall Survival After Progression of Oropharyngeal Squamous Cell Carcinoma by Carole Fakhry and colleagues. My name is Lori Worth, and I'm Assistant Professor of Medicine at Harvard Medical School and Massachusetts General Hospital in Boston, United States. My oncologic specialty is head and neck cancer. In the U.S., we are currently witnessing a dramatic rise in the incidence of HPV-associated oropharyngeal carcinoma, or OPC. This increase, seen over the last 15 to 20 years, is striking. Chaturvedi and colleagues reported on the changing rates of HPV in OPCs in JCO in 2011. They studied tumors from SEER registries and found an increase in HPV prevalence from 16% in the 1980s to 72% in the early 2000s. This is reflected in an increase in the incidence of HPV-positive OPCs by 225% over the same period. Chaturvedi predicted that by the year 2020, the annual incidence of HPV-positive OPCs will outnumber that of cervical cancers. And indeed, since this paper was published, we are seeing this epidemic unfold perhaps even earlier than predicted. Jamal and colleagues reported in JNCI in 2013 on SEER cancer incidence rates for 2009, at which point cervical cancer represented 33% of HPV-related cancers, while HPV-positive oropharynx cancer accounted for 37% of the total numbers of HPV-related cancers. This rapid rise of HPV-positive OPCs is thought to be related to changes in sexual behaviors amongst more recent birth cohorts in our population. Gillison and colleagues, for example, showed in a case control study published in JNCI in 2008 that HPV-positive and HPV-negative OPCs are associated with distinct risk factor profiles. While HPV-negative OPCs were associated with tobacco and alcohol, as expected, the risk of HPV-positive OPC correlated with the number of lifetime sex partners and number of oral sex partners one had. Interestingly, rate of HPV-positive OPCs is highest in white men, who typically present in their 50s. We now have results published recently in PLOS1 by D'Souza and colleagues from the recent National Health and Nutrition Survey, showing gender, age, and race differences that may explain both the increasing rate of HPV OPCs in our population, as well as different rates among different demographic groups. D'Souza and colleagues found that while most men and women report having ever performed oral sex, white men in younger birth cohorts report higher numbers of lifetime oral sex partners and had higher rates of oral HPV-16 infection compared to other demographic groups. While these data do suggest that changing sexual practices may indeed account for the rise of HPV-positive OPC and the demographic distribution of the disease, other unknown factors could also be contributing. The good news, though, in the midst of this emerging epidemic of HPV-positive OPCs is that stage for stage, HPV-positive OPC has a better prognosis than its HPV-negative counterpart. This was first appreciated in a retrospective analysis of the oropharynx subgroup of RTOG 0129, in which patients with locally advanced squamous cell carcinoma of the head and neck were randomized to standard fractionated radiotherapy versus concomitant boost radiotherapy, plus both with concurrent cisplatin. 64% of the 323 patients with oropharynx cancer enrolled had HPV-positive disease, and these patients experienced a significantly better 3-year overall survival of 82% compared to 57% seen in patients with HPV-negative disease. This better prognosis is most certainly due to differences in the biologic underpinnings of HPV-positive and HPV-negative head and neck cancers. HPV-negative head and neck cancers are driven primarily by field cancerization effects of tobacco plus or minus alcohol, whereas HPV-positive OPCs are driven by viral oncoproteins E6 and E7. While cigarette smoking is an independent negative prognostic factor for survival in HPV-positive OPC, there is no definite evidence that smoking in and of itself increases the risk of developing an HPV-positive OPC. And now, with several large-scale genomic profiling studies of squamous cell carcinoma of the head and neck, we know that when compared to HPV-negative tumors, HPV-positive OPCs show less genomic damage overall. For example, the whole genome sequencing and gene copy number study by Agarwal and colleagues published in Science in 2011 showed that HPV-positive cancers harbor fewer gene mutations compared to the frequency of mutations found in HPV-negative cancers. In HPV-positive disease, an average of 5 mutations was found versus an average of 21 mutations in HPV-negative cancers. They also found TP53 mutations absent in their HPV-positive cohort, whereas 78% of the HPV-negative cancers harbored mutations in TP53. Others are finding similarly low rates of mutations in HPV-positive cancers, though PIK3CA mutations have now been identified in some HPV-positive tumors. It is likely that beyond these and other differences in markers of genomic instability, there are other tumor-related factors that account for the improved cure rates in patients with HPV-positive disease as well, such as differences in anti-tumor immune response, which can be seen, for example, in differences in the presence of tumor-infiltrating lymphocytes in HPV-positive versus HPV-negative cancers, which several groups have now shown. The superior cure rates and younger age at diagnosis for patients with HPV-positive oropharynx cancer, coupled with the substantial toxicity of concurrent platinum-based chemoradiotherapy, which is the most commonly employed curative treatment approach at present, have raised a major interest in de-intensifying treatment for HPV-positive OPCs. Should we be subjecting patients with such a good prognosis to the rigors of standard chemoradiotherapy to the head and neck, which causes severe mucositis, pain and discomfort during the acute phase of treatment to the extent that many patients even need gastric feeding tubes in order to maintain their nutritional status, and has long-term impact on quality of life? Can we get away with cutting back on the intensity of therapy while not sacrificing the current excellent cure rates? We are coming closer to answering these important questions. For example, O'Sullivan and colleagues analyzed patterns of disease recurrence in HPV-positive oropharynx cancer and have shown that there is a low risk of distant metastasis in patients with stage T1 through 3 and 0 to N2 disease and N2B disease in whom patients were non-smokers. Thus, investigating de-intensification of systemic chemotherapy in this patient population seems reasonably safe. In fact, de-intensification clinical trials in HPV-positive OPC are already underway. RTOG 1016 is comparing cetuximab radiotherapy to cisplatin radiotherapy, while ECOG is just now launching ECOG 3311, a study of transoral resection followed by de-intensified adjuvant therapy, risk stratified for surgical findings. While our knowledge of HPV-positive OPC has grown remarkably since the landmark case control study demonstrating the link between HPV and OPC was published in the New England Journal of Medicine in 2007, there are still pertinent questions that we encounter in clinic every day. One big question is, how do we follow patients after the completion of curative therapy? The traditional approach to post-treatment follow-up of squamous cell carcinoma of the head and neck was to see patients at frequent intervals to guide them through the recovery process and to monitor for recurrent disease. Typical patterns of recurrence include local regional recurrence, for which careful serial head and neck examination is performed, and distant metastasis, such as to the lung, which can be picked up on thoracic imaging. Historically, squamous cell carcinoma of the head and neck patients with smoking histories are also known to be at risk for second smoking-related primary tumors, which is also considered in the long-term follow-up of our patients. But in this era of ever-increasing numbers of patients with HPV-positive OPCs who have an excellent chance for cure, do all patients need this level of intensive follow-up? Moreover, case reports and retrospective analyses have described unusual patterns of disease recurrence in this new entity, with metastasis in anatomic sites unusual for head and neck cancer that seem to occur late after the completion of therapy. Lastly, as we care for more and more HPV-positive OPC patients, we unfortunately are seeing more patients with recurrent disease. How do they respond to salvage treatments, such as surgery and chemotherapy? The analysis of the impact of tumor HPV status on patterns of failure and survival following disease recurrence from two prospective RTOG trials, 0129 and 0522, is reported by Fakhry and colleagues in the article that accompanies this podcast. Of the 1,058 patients enrolled on these two trials with OPC, 637 tumor samples were evaluable for P16 immunohistochemistry, which is considered the most practical surrogate marker for HPV. Progressive disease occurred in 23% of patients with HPV-positive disease versus 42% of patients with HPV-negative disease. Unlike the reports mentioned earlier, these RTOG data show that both time to disease progression and sites of disease progression were similar for the HPV-positive and HPV-negative patients. Median time to progression was 8 months in the HPV-positive group and 7 months in the HPV-negative groups, with a p-value of 0.67. In addition, similar percentages of patients had distant metastases, 46% for the HPV-positive group and 43% for the HPV-negative group. And the anatomic distribution of distant metastases was also similar, with lung being the most common, followed by bone, liver, then other. Despite these similarities, patients with HPV-positive recurrent disease had a much better survival than those with HPV-negative cancers. For patients with HPV-positive disease, median overall survival was 2.6 years, compared to 0.8 years in HPV-negative patients, with a p-value less than 0.001. Because information on post-progression therapy was not available, response to palliative chemotherapy could not be evaluated. Data was, however, available for salvage surgery for local regional failure. The rates of salvage surgery did not differ between the two groups, and of note, salvage surgery was associated with significant drop in death after progression for both groups, conferring a hazard ratio for death after progression of 0.44. Still, it is important to recognize that deaths occurred at similar rates in both groups even after salvage surgery. This study by Fakhry and colleagues has important implications to both the clinical care of patients with OPC as well as future clinical trial development. First, the authors recommend that the similar pattern of disease recurrence in HPV-positive and HPV-negative OPCs implies that patients should undergo the same close surveillance following initial treatment given with curative intent, at least for the first 2 years of follow-up. They also point out that the benefits of salvage surgery on survival should be taken into account when counseling patients on treatment decisions, though a cautionary note that surgery does not successfully salvage all patients with local regional recurrence, even those with HPV-positive disease, should be made. Lastly, it is clear that the survival of patients with recurrent metastatic HPV-positive disease is much better than that of patients with HPV-negative disease. Not only will this information be a great help in caring for our patients with recurrent metastatic OPC, it must also now be taken into account in planning future clinical trials investigating new approaches for such patients, which absolutely must stratify for HPV status. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.